Sangwan, and he's a director and innovation at Shroff's Charity Eye Center right now in Delhi, and he'll be speaking on the SLET revolution. There's no stopping it.
All right, thank you very much, and very briefly I'll talk about the SLET and what it has reached. This is a patient who we saw in sometime 2006 when he underwent a LASIK, and followed that he developed a fungal infection. He works in London, came back to Gujarat, and there he was told that it's very difficult to save the eye. The LASIK flap was amputated, but then he underwent a large therapeutic graft at LVP, followed by a cultivated limbal epithelial transplant, and then followed by a PK with cataract surgery, and at least 50-60% of his vision was restored. We will skip this part because this audience is quite well versed with the limbal stem cell deficiency, and the treatment of which we started way back in 2000 in LVP, starting with the cultivated limbal epithelial transplantation of harvesting the limbus, growing the cells on the seat of amniotic membrane, and then transplanting back. And this is how that surgery we have been doing. And there is extensive literature created on this particular topic, and success of these transplant over 10-12 years. The problem we started thinking with the cultivated limbal epithelial transplant is it's very expensive, and most of the clinicians will not have access to this. Therefore, and also in pediatric limbal stem cell deficiency, the outcomes are suboptimal. So we started thinking how we can start, innovating or simplifying this limbal stem cell transplant, and that's where the technique of SLET was developed. Started somewhere in 2009, and 2012 we published the first paper. The technique is widely practiced. This is the first, I think, the largest paper that Science published on this topic, and till date, I think, still remains the largest paper, with a very extensive outcome, both two, three outcomes that were very important here, demonstrating that adults and children LSCD both are equally responsive to SLET. The visual outcome are also comparable, and also whether the SLET is done by a fully trained or experienced surgeon versus a trainee, both were equivalent, and this technique is very easy to teach. These are some at the cell level, the validation that these are not what we are seeing. There is at cellular level, there is a reconstitution of the epithelium. These are outcomes before and after. This is 3-year follow-up, and this is a 10-12-year follow-up, and I hope that Sayan and his team will come out with a paper with at least 10-year follow-up of SLET, where we can demonstrate the stability of these results, which are achieved in short 3-4 years follow-up. Both of these patients are having 10-12 year follow-up, and these are confocal microscopy, and these are the slides contributed by Sapna from LVP. And so you can see the stability of the results and reconstitution. Another feature, patient undergoing SLET, we notice that there is a continuous stromal clearing, and that is the basis that Science just now showed about stromal keratocyte-based treatment of the corneal scars. So here you see this patient did not want further surgeries, and if you wait long enough, the cornea continues to clear. And this probably is the work of the mesenchymal cells that are part of the explant. The pediatric, like this is a slide contributed by Vikas, who has been doing the SLET from a long time. This is a pediatric patient with 14-year follow-up. This is pre-op and that 14 years follow-up. This is a innovation which Swati Kalki from LVP for the use of SLET in primary excision of OSSN. If the OSSN is like on the upper less than 2 or 3 clock hours, probably you don't need anything. If it's more than that, like lower pictures, you would need a combination of the primary SLET with the excision. And earlier I had seen that patient who underwent OSSN excision and chemotherapy and developed limbal stem cell deficiency, their outcome with CLET were not very good. So I think this is a very smart and good innovation in a far good management of OSS, and especially those are very large. Then there are many other innovations reported by different groups. This is another large study by a multi-center trial where surgeons from different cities in India and different countries collated their results and showed exactly what we had shown in 2016 in ophthalmology paper. This is a repeat where the CLET failed, the SLET is successful. So when you look at these 7 parameters, to me it looks like the SLET scores on all the parameters among the 3 techniques which are prevalent. These are further modifications. And now we are seeing papers. This is like from Boris Malgun's group in Moscow. They have shown you don't need a amniotic membrane or you don't need a fibrin glue, so you can still do limbal SLET and it works very well. You would see that if you look at the publications and the number of reports from different countries, it's really grown global. And this is the global picture and the publications. When now if you last looked at around 80 or 90 publications till date. Most important, I think, is this slide where we've shown that the cost of doing SLET is 1/10 of the CLET. Number 2, it is the true democratization of the technology where everyone who can learn wherever they are based, you really don't need anything other than your patient and your instruments. So in summary, this technique is very effective, replicable, repeatable, affordable and reliable, and it's really a platform technology which allows innovation by different surgeons around the world. Thank you very much.